I'd like to welcome everyone to the second Older Adults Injury Prevention Seminar, the How to Prevent Medication Poisonings in Older Adults, and also a special welcome to all of those who are attending over via video conference. If you could please put your microphones to mute if you haven't already done so. I'd like to start by acknowledging the Aboriginal and Torres Strait Islander peoples as the traditional custodians of this country and its borders, and wish to pay my respects to the elders past, present and emerging. Just a little bit of housekeeping before we get going. If you need the bathrooms, they're just out the door. If you just keep going to the end and through the kitchen, the toilets will be just out the door on your right. We will be taking photographs today, so if you don't want your photograph taken, it will just be for social media purposes. Can you just let one of us know? And we won't do that. Making sure telephones are off or on silent. And we will have time at the end for questions. So if you have any burning questions, saving them to the end because one of the other speakers might be able to answer it before we get there. So today we have three great speakers lined up to talk and share with you their wealth of knowledge and experience in assisting older adults with the correct administration of medication. So first up we have Dr. Anne-Marie Lynch from the WA Poisonings Information Centre, followed by Mark Coles, a clinical consultant pharmacist, and Nagar Masi from 777 Pharmacy. So today's seminar is delivered by Injury Matters through the No Injury program. So Injury Matters is a for-purpose, not-for-profit agency leading the way in preventing injury and supporting recovery in WA by providing programs and services that enable West Australians to live long and healthy lives. We achieve this through the delivery of three core programs: Stay on Your Feet, No Injury and Road Trauma Support. So Stay on Your Feet is our force prevention program for older adults living in the community. Our road trauma support program is a free counselling service for people that are affected by road trauma, whether you're involved in a car crash or a first witness or a responder. It is a free counselling service for everyone, and also No Injury. So it's through this No Injury program that we are delivering today's seminar. So I'd like to acknowledge the state government through the Department of Health who fund the No Injury program. So No Injury aims to enhance the capacity of people and organisations to deliver evidence-informed injury prevention and community safety activities. We do this through the three core principles: Know, Learn, Connect. So Know is knowing about different types of injury. Learn is about learning about injury prevention practice. We do this by providing training around public health approach to injury prevention. And connecting, which is about connecting with other people and agencies who are conducting injury prevention around WA. So if you'd like to find out more information about the No Injury program or how you can get involved, please don't hesitate to come and have a chat with myself or one of my colleagues at the back of the room in the morning tea break after the presentation. There are also a few resources in your packs on your tables which has a bit more information about the three programs as well. So our first presenter today is Dr. Anne-Marie Lynch. So Dr. Anne-Marie Lynch holds a PhD in reproductive toxicology from UWA. She's worked at the WA Poisonings Information Centre since 2000, initially in the role of Research Officer associated with Emergency Medicine at UWA. Anne-Marie was appointed Head of Department at the WA Poisonings Information Centre in 2007. So thank you, Anne-Marie.
Thank you. Thanks, Ellen. So upping the slide is just...
If you just press across, yeah.
Okay. Well, good morning, everyone. It's nice to be here. I'm just going to provide some data from the WA Poisons Information Database on medication errors in the elderly. Some of the data I've extracted from 2010, some from 2017, and there's some national data where we, the National Network of Poison Centres did a collaborative study on all exposures in 2015. That's all right. So the aim is to provide a description of what the PIC data specific to medication errors in the elderly population, and possibly to identify some useful strategies that we could adopt to reduce unintentional poisonings in the elderly. Just a little bit of a background on the WA Poison Centre. We're located at Sir Charles Garden Hospital. We operate 7 days a week. We take roughly 40,000 calls a year. We provide a service to WA, South Australia and Northern Territory, and we collaborate with the other 3 poisons information centres to provide a 24-hour, 7-day-a-week network to the nation. The data that I'm presenting here today is of WA origin only. So I extracted data from the WA PIC database for 2010 and 2017, where elderly is defined as 75 years and over, and case data was examined in relation to the age and gender of the victim, the circumstances of exposure, the substances involved, some details of the exposure, which, as you can appreciate, if we're a phone advisory service, the amount of detail that we get is captured in a short period of time. So, you know, where things are stored or some of the other details about how things came about is lacking. Poison severity, which is based on an internationally accepted poison severity score, and really how many people we needed to send to hospital. So in 2010, we handled 40,000 calls, just over 40,000. And in 2017, that number slightly dropped a bit, 38,000, but the proportion of calls that we handled from WA was steady. So if we look at case number, this is just to get a perspective of the elderly in relation to across all age groups of what we handle. And you can see that toddlers really are just about our number one issue, but that's toddlers crawling and getting into cupboards and putting things in their mouths, and so they represent a large proportion of calls to PIC. The elderly appear to be just a small group, however, they're an extremely important group given their vulnerabilities. If we look at exposures, so that types of things that happen to the elderly as opposed to other age groups, where we've got age groups on the horizontal axis and a percentage of all exposures. And I'm not sure if you can see this very well, but we have the pink is accident, and the next group up is therapeutic error. And you can see that in that's with the elderly in the extreme. Does that work? On the right-hand side, that the vast majority of calls to the Poison Centre that involve elderly people all involve therapeutic errors. Whereas if you look at toddlers, they're all pretty much all accidental things, just running with things, drinking bleachers or getting stuff in their eyes. If we look at circumstance of exposure for the elderly in 2010, again, this is reflected in WA PIC data. So by and large, most of the exposures are therapeutic errors. A very small proportion of suicides, which is an interesting thing in itself, and a small proportion of adverse drug reactions. But essentially, the problems facing elderly are therapeutic errors. And the same holds true in 2017 data. The proportion of therapeutic errors had actually increased over that period, and the other types of exposures, accidental, clearly there's few occupational exposures, but predominantly this reinforces that the problem is therapeutic errors. And then if we look at what they're exposed, what substances are the elderly taking across all exposures, and you can see the vast majority are medications. This is all exposures, not just therapeutic errors. So we've got a very small amount of snake bites there, a small amount of caustic injuries, occasional ingestion of a button battery, but the wealth of, the bulk of all these exposures are pharmaceuticals, and you've got antihypertensives, paracetamol, other analgesics, really representing the bulk of the exposures. Now, there's more substances here than there are case numbers, and that's because often with the elderly, that's another issue. The errors will be taking multiple tablets. So whether it's in a compartment in the dosette box or whatever, they're on a large number of tablets often, and any mistakes will involve not just one tablet, but may involve five or more. And so there'll be different types of medication depending on their needs and their chronic disease states. The other thing that's interesting from this graph is that with beta blockers, antihypertensives, other cardiovascular drugs, including digoxin, warfarin, diabetic medication, and some of the analgesics, they are quite potent drugs. They're not drugs where there's a wide, a lot of room for error. They're often drugs where in some cases, a double dose of some of the cardiac medication could put this patient at risk. Things like antibiotics and medication that you used for peptic ulcer and so forth are relatively low in toxicity, and consuming several of those sort of tablets usually leads to no harm. But in an elderly person with pre-existing heart disease who makes an error with some of their cardiovascular drugs, that could put them at certainly their life at risk. Just briefly touch on a definition of a therapeutic error. There's lots of definitions, but just to try and keep it simple, it refers to an exposure resulting from a medicine used incorrectly, whether the agent was administered by a medical personnel or by a lay person. So this can be the wrong medication, the wrong dose, the wrong route of exposure, the wrong patient, and the wrong time of administration. And I thought when I was examining this data that I'd actually bring up a lot where there are therapeutic errors in nursing homes where medication had been given to the wrong patient, because that's what I would regard as fairly common called poisons, and in fact they're few in number. Almost all the cases in this age group would appear things occurred at home and where the individual patient has made the error, or their carer, their husband has made the error. This is just another breakdown of the medications involved. So we can see that cardiovascular drugs top the list. Paracetamol is up there, anticoagulants, anti-diabetic medication and opioids. So if we just look at the top 5 groups, they're all groups where you can lead to serious life-threatening toxicity with relatively small errors, particularly the opioids and some of the cardiovascular drugs. And what sort of medication, also looking at whether this is prescription medication or non-prescription medication. The elderly's in the bar on the right-hand side, the elderly group, and you can see that overall a proportion of all the medication in which errors are made, non-medicinal is small, over-the-counter medications are small, and again, the bulk of it, almost 75% of the errors are with prescription medicine. Over-the-counter may or may not include paracetamol. I suspect that some of the Panadol is listed within prescription medicine because it would be descript, the Panadol, Osteo, so forth would be part of their script and would be in their dosette boxes. But, you know, they also may buy additional paracetamol or something over the counter. So in 2017, we had 221 cases of therapeutic error in WA reported to the Poison Centre. The majority of the victims were female. The average age was 83. And where did this exposure occur? The bulk of them occurred in the home, the patient's own home. Only 21 occurred in nursing homes, and the patient, it was an error made in a hospital in an inpatient facility, but overwhelmingly it's occurred in the patient's home. And we have an internationally standardised poisoning severity score that we use the time of the phone call to pick. So often cases are reported to us sometimes within the first few minutes. With the elderly, it may be several hours later or even the next day when someone goes to check on them and realises that you've got 4 days worth of medication missing from the dosette box and they're unaccounted. But generally, calls to pick occur not long after the event. And in this scoring system, the initial severity was scored at the time of the phone call to pick. Most people were asymptomatic. More than about a quarter were exhibiting minor features of toxicity, and a small but not insignificant group were exhibiting moderate features of toxicity. And to score moderate on this score is actually quite ill. It was devised by intensive care specialists to manage poison cases in Sweden as a scoring system. So moderate is really actually life-threatening. And based on advice, that number, that N should be 202, not 102. We could advise for 145 people with advice from PIC, we could advise that they could stay at home or at the location of the poisoning, but we referred 51 to hospital, and there were already another 20 or 30 or so already in hospital at the time of the call to PIC. So that's a large proportion of referrals. In no way would we refer a quarter of all toddlers to hospital from calls that to the Poison Centre. And again, I think that this reflects their vulnerability, their pre-existing medical conditions, the types of medication they're on, their lack of tolerance to even things like double doses of some of their cardiovascular drugs that could put them at extreme risk. And I'll just run through some examples of some of the calls to PIC. This was taken out of the comments section of the Poison Centre database. So one call was involving a 75-year-old female from Mandurah. She's prescribed vasocardal, 360 milligrams in the morning, Tevitin plus at night, and she's woken up and taken both tablets. She's taken her evening medication, which is an antihypertensive, which isn't particularly potent, along with her vasocardal, which is extremely potent cardiovascular medication. In a 40-year-old, this sort of mistake could be tolerated. In a 75-year-old, depending on her background, there's really no leeway, and she's likely to, considerably drop her blood pressure, and should be a falls risk, and she lives alone. So this would necessitate really she'd need to go to hospital. This was called from the daughter-in-law arrived at the home of an elderly man to find his Friday, Saturday and Sunday medications missing from his dosette box. He can't remember when he took them. he can't tell her when he took them, and she's concerned that he's taken 3 days' worth of medication. And again, he's on cardiovascular medication, lipid-lowering medication, he's got some bladder issues, and he's, again, on an antihypertensive. Just that his calcium channel blocker, 3 days' worth again would put him at severe risk. But in this situation, we don't know when they were taken. He's asymptomatic and he can't remember when he took the tablets. This is an elderly female from, excuse me, from Esperance, sheep-bone poisons, and she knows what she's doing. She's not confused. She realises she's made the error, and she herself has phoned the Poisons Information Centre. She normally takes, she's an insulin-dependent diabetic, and she normally takes 26 units of Novomix in the morning and 8 units at night. And today she's accidentally gone and injected another 26 units of her insulin at night. This is a large dose. Again, she probably lives at home. She's not far from Esperance Hospital. She can't stay at home. It's night time. She needs to go to sleep, and it's going to considerably drop her blood sugar level. So she's at high risk. And this, unfortunately, is becoming more common, this sort of error with sometimes it's dispensing errors with pharmacists, sometimes it's just confusion and misunderstanding and not getting the message across in terms of, you know, how the medication should be taken and on what days. So elderly female who is prescribed methotrexate. Methotrexate is a safe drug if it's given as prescribed, and normally in this case it's prescribed once weekly, 1 20 milligram tablet that she was advised to take on a Friday. However, for the past 6 days she's been taking 20 milligrams daily. That's possibly a lethal dose. It causes bone marrow suppression. There have been some cases recently across Australia and one in WA where people have, in one case in WA, it was the GP who had made an error on the script. The pharmacist was aware that it was an excessive dose but still dispensed the script, and the patient followed the advice of the script. In this case, we have an elderly person who confused that, and it sounds reasonable. You know, it's an odd thing to do to only take 1 tablet a week. And so she's been taking it daily. And this suppresses your immune system in high doses, such as this, and particularly in an elderly person. It's going to suppress her bone marrow production of her white blood cells. And she already has mouth ulcers, which is sort of an indication that she's running into trouble. And the last one is another tipping one. This patient's confused but managed to phone the Poison Centre, an elderly female that lives in Booragoon. She's on multiple medications, but she's a bit grumpy, and she wanted advice about her warfarin, but she wasn't going to let anyone know what else she's taking, but she clearly was aware that she'd made a mistake with her warfarin. And it seems that the dose had changed recently, and this is another common theme, that they change the tablets or change the dose. She's been prescribed 3 milligrams of warfarin recently, and she's got confused, and she understands. She's pretty clear that she thinks that she's taken too much warfarin, but she's not sure what she's taken, and she needs blood tests. And warfarin, again, there's not a lot of leeway in warfarin. Warfarin ideally should be taken exactly at the same time every day. There's all sorts of things that interact with warfarin, but if it's taken, as prescribed, exactly as prescribed, it's usually safe, but they need ongoing monitoring of their clotting times. And this woman did need to go to hospital, but she was quite defiant. She said she didn't like hospitals and she'd rather die, so she wasn't going. So there's not if the call record doesn't really explain the conversation that went on, but no doubt there would have been quite a conversation about who can we get to come to the home? Is there someone that can take you to the hospital? What can we do? And so forth. But in the end, she consented to have an after-hours GP come to the home, so at least we got some assistance to her, and presumably that after-hours GP could advise her that she needed to have an INR blood test. The last one is a 97-year-old female from Gospels. Her husband is her carer, and she had been prescribed a half a tablet of alprazolam. Obviously, she'd been having trouble sleeping, so alprazolam is fairly potent. But she had been prescribed half a tablet each night to help her sleep. Her husband noticed that she was a bit drowsy yesterday, but for the past 2 weeks, he's been giving her a whole tablet. And he's phoned in the morning because he's gone to get up and he can't wake her, and she's unrousable, and she needs an ambulance transfer to hospital. So I'm sure that everyone in the room will be thinking about, in terms of the interaction between these problems, and they're complex problems with the elderly, but very simplistically there are issues with the victim, the substance and the environment. And where the victim, obviously they can have their memories maybe poor, they may be forgetful, they may not clearly understand. In the case of the methotrexate issue, did she understand that those tablets were only to be taken weekly and not daily? Their eyesight and hearing's failing, they can't have difficulty reading small font, and with their manual dexterity and with arthritis and so forth, they often, although it hasn't come out in this data, but they often elicit strategies to help them get the tablets or get things out of pill bottles or make it easier, even with the dosette boxes. So they may put them out on the bench instead of leaving them. So this also poses a risk for other people picking up the tablets, or the partner picking the tablets off the bench. But all of these things are issues for the elderly, and we also have declining physiological function and disease states. So it means that they clear drugs at a slower rate, whether their renal function's impaired or their liver function may be impaired. And because of the complexity of their chronic disease states, it means that they're extremely vulnerable to errors that may be tolerated in fitter younger people. And the substances, many elderly are on a large number of medications and tablets. Some, as I mentioned before, things like opioids and cardiovascular drugs and insulin. They are quite potent drugs. They have just small doses can cause toxicity, and there's issues with the formulation, the dosage pattern, the storage. And it's not an easy issue. They often will complain about pharmacists substituting a tablet for a different tablet where the names confuses them. It's the same medication, but it's got a different brand name, or it comes in a different colour, or all those sort of things add to the confusion and enhance the risk. And the environment. From this data, it would appear that in the elderly, most of the errors are occurring in their own home, but the degree of support that they have, how supportive their family are, what sort of carer support they have, also the skills of the carer, which doesn't come out in this data, but the skills of the carer are sometimes, extremely limited, and carers often phone the poison centre and are aware that a mistake has been made, but the carers have no skills and no training in medications at all, and often cannot appreciate the difference between the potential toxicity of something like a fish oil capsule and digoxin, and they don't know how to pronounce them. Their knowledge is virtually zero. And the same issues that we're all aware of, the social isolation. And then also, I'm sure other speakers will mention this, but the important role of GPs and pharmacists in all this, and good communication. So this is not an easy problem. It's a complex problem. It has social issues as well, and it has certainly communication issues. Okay, thank you.
Thank you. Thanks, Anne-Marie. It's really great to get that overview of these, I guess, these therapeutic areas and some of the case studies to see, I guess, how these areas are happening in the community. I think it's a nice introduction to our next two speakers. So next up, we have Mark Coles. So Mark graduated with a bachelor's degree in pharmacy in 1979, successfully completed a diabetes educator course in 96, asthma's educated course in 2003, and completed and graduated with a Master of Pharmacy, Clinical Pharmacy degree in 2007. Mark is a regular reviewer of diabetes drugs for the Australian Medicines Handbook and previously served 7 years as a clinical pharmacist advisor on the Clinical Practice Committee on Australia's Diabetes Educators Association. Mark has a keen interest in the management of type 2 diabetes, cardiovascular medicine, geriatric medicine, asthma management, dementia, pain management, and quality use of medicines in the elderly. Mark is currently working as a consultant clinical pharmacist, undertaking comprehensive medication reviews in aged care homes and providing quality use of medicine services to general practitioners, allied health professionals, and staff of residential aged care facilities. So I'll pass you over to Mark, and I'll move this computer down for you so you can
thank you.
see it as well.
Is that okay there? Is it?
Yeah, that's good. It's easy fix.
I only do this on the weekends. I just have to look at the slides as they come through. So that highlight button doesn't work. Is that right? It doesn't do it on the TV. Oh, it's right.
That's right.
We'll go with that. That's fine. All right, there we go. Thank you for having me. Thanks to Dr. Anne-Marie Lynch for introducing that with the data. It was most interesting. Talking about those drugs, which is not much difference between what is the toxic and the therapeutic dose. One of the ones I'll briefly mention here is digoxin, which is a classic one, which has what they call a low therapeutic index. I'm going to be talking about the older adults medication use and then how medications, why it's different, the effect of medications in elderly people, and then we'll just briefly cover polypharmacy and the dilemma we have with polypharmacy. Okay, the effects of medications, well, they certainly, we find medications change their effects as people do get older. And these age-related changes probably started about 65 years of age, but they really begin to accelerate from 70 years onwards. And really, we can put these changes down to two areas of the drugs, and they're called the pharmacokinetic and pharmacodynamic properties of the drugs in older people. And that's really what I'm going to concentrate, explain to you what those are, and then how they do change in the elderly. And we also have to remember, up until probably about 10, 15 years ago, most of the drugs, even those drugs that were intended for older people, quite often used in older people. That's many of the cardiac drugs and such. When the testing was done with it, quite often there was a cut-off age and they weren't given to people over 65 years of age. So, for example, blood pressure tablets were tested on people under 65 years of age, but then, of course, and it was just extrapolated and they'd just give the elderly the same doses with that. And that in itself created a real problem. Okay, so when we talk about the pharmacokinetics of a drug, or the effect of it, what we're talking about, if you think of the word kinetic, that means movement, and kinetics in anything means movement. So we're looking at the movement of the drug in the body, and that relates to its absorption, its distribution, its metabolism, and its elimination. The drugs in the body, they're absorbed, most are taken orally. So if they're taken orally, then what happens is we swallow them, they go down the esophagus, into the stomach. Very few drugs absorb from the stomach, but some are. Most actually go into the small intestine, where most of the drugs are absorbed. then anything that's actually absorbed actually goes into the portal circulation. But not all the drug is absorbed. So in actual fact, you may find that for some drugs it could be as low as 2 or 3% is actually absorbed into the systemic, into the body, whereas other ones it could be 80 to 90%. So we don't get 100% absorption. Of course, when we give injections, then we bypass that. So that's why quite often you'll see doses, for example, some of the opioid doses, they'll be higher, some of them when you give oral tablets compared to what you'd be giving an injectable form, because you're allowing for the fact that when they're absorbed, you're going to lose some of that drug as it goes through the gastrointestinal system, and it won't get crossover into the systemic, into the blood system. Once it's absorbed, it goes into the portal circulation. This is oral, again, going back to oral. And that means everything that goes into the portal and all things that absorb go into the portal circulation has to pass through the liver before it gets to the rest of the body. And the liver is the place, it's our protection place. Certainly with drugs, it's where drugs are broken down. And that first pass that the oral drugs go through the liver is called a first pass effect with it. Now with drugs, that first pass effect could mean up to 95% of that drug gets actually broken down as it goes past the liver first time round. Or it could be much lower than that too. But it is a significant effect it has. And then it gets into the system and it's distributed around the body. And I'll discuss that over the next page about how this differs in the elderly, why the drug distribution occurs differently in the elderly. So it's absorbed, we start to get some metabolism as it first goes through into the system, it's distributed around the body, then as it continues to go around the body, some will keep going through the liver and we keep getting it broken down. The liver, it is broken down in other areas, but the liver is the main area it breaks down. And then we eliminate the drug. The main way we eliminate drugs is renally, through the kidneys. Again, there are other ways. We can actually get some rid of through our bile duct, and there are other mechanisms by which some drugs are eliminated, but predominantly it's the kidneys that actually is the way we get eliminated. These things change in the elderly. So for that single dose of drug that we're going to talk about, the end effect is quite significant. So that's the movement of the drug. That will change in the elderly. And then we have what we call the pharmacodynamic effect. So for the same concentration of drug, for a younger person, say 30 years of age, compared to a person who's 80 years of age, that same concentration, when it gets to the place it needs to work, the effect in the elderly, generally speaking, is significantly higher, and they're far more sort of sensitive to that effect, that magnitude of that effect, in the elderly than they are for the younger person. This is basically a slide I bring up when I talk to the third-year nurses about the effects of drugs in the elderly, and that covers what I'm talking about. As you'll see, put it in blue, metabolism, distribution, and excretion, they're the pharmacokinetic effects. And I've put it in the pharmacodynamic effect at the point at which it occurs when the drug actually interacts and has its effect in the body. So as we get older, with regard to absorption, our esophageal, that's where we swallow down the tube that goes down to the stomach, motility is decreased, and so therefore things go down there a little bit slower. And our gastric emptying times, because things sit in the stomach for a while, that's actually increased. And so what happens is that the end result of that is that things are moving slower into the small intestine. The effect of that in the elderly is there is a delay sometimes in the absorption, though the end effect, as far as their sensitivity to that medication, is very little. So absorption, even though in the elderly it is slowed somewhat, generally speaking, there's no net problem or change in effects. But it's after that time that we start to get some real effects happening. So the drug's absorbed, it's in the body, it's actually in the systemic system, bloodstream, and in the body tissues. What happens is with metabolism, particularly those, remember that oral one that said there's that first pass effect, which could be quite significant. All drugs go through the portal system and then they get hit first time by the liver, which really knocks a lot of it out. As we get older, our liver weight is decreased, and also the rate of flow of blood to the liver is decreased. The end result of that is that there's a slowing of the rate of metabolism of the drug. It's still metabolized, it's still broken down, but the rate slows down. Not so much significant with the first pass effect because all the drug has to go through at that time, but subsequently there's only a proportion of the drug going through the liver at any one time, and that can have a significant slowing and effect of that metabolism or breakdown of that drug. So the result of that is the drug is staying, active drug is staying longer in the body at higher concentrations. You get repeated doses and therefore you get an add-on effect with that. That's one effect. So metabolism is decreased. Then with regard to how the drug, when it's in the body, it's in the blood, and it goes into all the systems and it gets distributed around the body. In the bloodstream itself, we have proteins called serum albumin. And in actual fact, drugs quite often bind to that serum albumin and they're carried around the body. The percentage of drug that's bound to that serum albumin can vary, and some drugs, for example, like warfarin, a very high percentage of warfarin is bound to serum albumin, and there's only a small percentage of free drug in the body. The free drug in the body is the only drug in the body which is free to act. So if you've got something which is, say, 90% serum bound, then 10% of free drug floating in the body, that's the amount that can actually act at any one time. So that bound to the serum albumin can't act. As we get older, our production of serum albumin drops with time. And therefore, if there's less serum albumin to bind that drug, when that one dose is absorbed, there's more free drug for that one dose floating around, and therefore a greater concentration of that drug ready to act for that one dose. And a classic one of that you can look at is sodium valproate, which is epilum. And in fact, epilum, if we have low serum albumin levels, can significantly affect the concentration of free epilum in the body. And you can very easily, if they have very low albumin, can have toxic effects with epilum with that. I'm just going to have a sip of my water. Also, in the body, to distribute it out, it's like when we dissolve something. Okay. That's pretty much the same. All right, consider, you people can't see this, but I've got 2 glasses of water. Consider one being totally full and the other one being half full. If we dropped a cube of sugar into each of those, same size cubes of sugar, you would find that the one with the greater volume of water will have the less concentration of sugar in it. The one with the half of, whoops, I just put half of water in it, will have a greater concentration of sugar. Let's talk about digoxin, which is that potentially very dangerous drug, but also a lifesaver at the same time. Digoxin is dissolved in water. It's aqueous dissolved. It's actually, that's its main way. That's what it likes to do. As we get older, our total body fluid is decreased. So water-soluble drugs like digoxin, for that same single dose in an elderly person, will have a higher concentration without any other things changing because there's less water in the body. Digoxin is one of those medications which is also renally cleared, so it comes in a little later on, but it has a therapeutic index of what we call 2. That means that it's a ratio of 2 to 1, where the higher the number 2 is, you put the average toxic dose over the average therapeutic dose. And the average toxic dose over the average therapeutic dose for digoxin is 2/1. So it's only double the therapeutic dose is the toxic dose for digoxin. So the potential there for toxicity, if you've got this drug in the elderly where there's less, and it's a water-soluble one and it has a therapeutic index of 2, and there's less volume of water for it dissolving, is much greater, say with digoxin, the potential, than it is than in a younger person. And then we have the ratio of body fat is increased in elderly people, and this affects the distribution of drugs as well. And in this case, what happens is, for example, I'll give you an example, diazepam, which is a benzodiazepine. That is a fat-soluble drug. Now, if with these fat-soluble ones, if the ratio of body fat's increased, what happens to the drug which is fat-soluble? The time it takes to get eliminated in the body is increased as well. So it takes longer to get rid of the drug from the body. With digoxin, the elimination half-life, that's how we measure how we get rid of drugs, that's the time it takes to get rid of half the drug out of the body from one dose. The elimination half-life for digoxin could be around 20 to 30 hours of that. So that's with a 20-year-old or 25-year-old. With an elderly person, the elimination half-life of, diazepam, I should have said diazepam before, the elimination half-life could be up to 100 hours. So there's a significant change. That diazepam will stay in the body a lot longer for that. I'll leave the receptors for the moment and I'll go to excretion. Now this is how we actually get the drug out of the body. And the main way we do it is through the kidneys. And our kidneys certainly start to, as we get older, their function, I think they put it down from 40 years onwards, you decrease your kidney function by about 1% per year. I don't know how accurate that is. But certainly tubular excretion, that's active excretion from the kidneys, is decreased. The passive way, which is called glomerular filtration, just the filtering that occurs, is decreased. And the renal blood flow to get that filtration to occur is decreased as well. So for the renally cleared drugs, like you have, for example, digoxin, so I give you digoxin, you find that you're younger people here, the glomerular filtration rate, you may be filtering 120 mils per minute. An elderly person may be only filtering 35 mils per minute, much slower. So renally impaired drugs, they're slower to get rid of those particular drugs. So for that one dose of drug, we have reduced metabolism, greater concentrations, being longer in the body if it's fat soluble, and we're also getting slower excretion. So that one dose of drug the effect can be a much greater effect in elderly people. And given the fact that those elderly people, for the same concentration of drug compared to a young person, are much more sensitive anyway to the effects of that drug, then what happens is that increased level of drug in the body for that one dose will just compound or exacerbate that effect significantly. So what I'm trying to get to you there, this is basically the reason that the elderly are far more sensitive to drug effects than younger people. Oops. So, compared to younger people, a single dose of medication given to the elderly will result in a slower metabolism, a reduced breakdown of that drug in the liver, and a reduced clearance of the drug and or its metabolites from the kidney. Higher concentration of that drug therefore remain for longer periods of time in the elderly, and given that greater sensitivity of the elderly to the drug's effect, the net effect is much more potent action of that dose in the elderly person, including a greater propensity for side effects. The risk of adverse drug reactions and toxicity are significantly increased in the elderly, and much of it is to do with this pharmacokinetic, change in pharmacokinetics and pharmacodynamics of those drugs. But there are other factors, as Dr. Lynch pointed out there, about the cognitive level of the person too, and their ability to know what they're doing and understand the complexities of medicines, which we'll be going on to a bit in polypharmacy. I've got this terminology of adverse drug reactions from an article, Mr. Smith, Adverse Drug Reactions, Allergy, Side Effect or Intolerance, Australian Family Physician. And it really covers it quite well, I believe. We won't go through all the classifications, but really just looking, and I've highlighted those ones in red, which certainly those changes in the elderly will have a significant impact for. So side effects, as I've already said, they're at much greater risk of side effects because of that much increased sensitivity to the drugs and increased levels of drugs in the body. If you already have an intolerance, that's again a pharmacological effect, but a particular susceptibility, which is an individual susceptibility to the drug, well, you'll even become more susceptible to those drugs because of that change in pharmacokinetics and pharmacodynamics. You become at much greater risk of toxicity because lower drugs will cause toxicity compared to what the levels you would need in a younger person. So lower doses of those drugs. And something which we were talking polypharmacy, because people are taking multiple meds and the elderly are therefore often more susceptible to interactive effects of drugs. Okay, let's go on to polypharmacy itself. I think we've defined there perhaps some reasons why the elderly are far more sensitive to medications. Polypharmacy, the definition we tend to use here in Australia and pretty well most places overseas, would that be right, Dr. Lynch? Is that taking more than 5 medications in 24 hours?
I'm not sure on the definition.
I think one country does 4, but yeah, that's all right. But the reason they came up with this definition was there was a study undertaken that showed that people taking 6 or more medications statistically were at 100% risk of having some adverse effect. That's how they came up with it. But really, polypharmacy is the concurrent use of multiple medications. And certainly, although it can be associated with the prescribing and use of too many or unnecessary medicines, at sometimes doses or frequencies higher than therapeutically essential, we have to remember that doesn't always happen, that multiple medications are often necessary and can constitute best care for patients. They did a postal survey in, 2009, 2010. They sampled 4,500 Australians aged 50 years and above. And they got a 37% response, or 37.3% response, thank you, which is about 1,700 people, which is a pretty good response. And they found from that survey 87% took 1 or more medications in the past 24 hours. Complementary medicines, or herbal medicines, some people call them, were used by about 46.3% of participants. 84% of those people used both conventional medicines and complementary medicines. Doctors recommended 79.3% of medicines, of all their medicines, and 93% of the conventional medicines they were taking. Pharmacists commonly recommended occasional PRM meds because that's often what they do recommend when people go in and they actually have a suggestion. They're dispensing other people's or doctors' prescriptions, but their recommendations is often on PRM medication. People go in to see them. And family, friends and media, we shouldn't forget these because they have a great impact on what we do with our medications. Most influence the use of complementary medicines. But the really interesting figure, and this is 50 years and above, is that 43.3% took 5 or more medications in the last 24 hours. And that's 50 years and above. So I reckon, and this is just my opinion, if we gave this survey to people who were 70 years and above, that figure would be even significantly higher. But I was still quite astounded that 43.3 of people just 50 years and above, because 50 years is still pretty young. I'm turning 60 next month, so I'm still pretty young. But here we have this dilemma. And what is the dilemma? The dilemma is of polypharmacy and the elderly. Because on the one hand, the incidence of chronic disease increases with age. And disease management will often include the use of medications. Because I know, people sometimes can't say they're taking too many medications, but some of these medicines, and many of them do save lives and keep people going and keep them active and living longer with it. But at the same time, these medications will also cause problems for those people, or can or may cause problems, because the elderly are much more sensitive to the effects of the medications and therefore much more susceptible to their side effects. So that is the dilemma. The people who need the medicine most are going to have the most potential problems with those medications. But we do have to keep in mind that polypharmacy is not a clinically useful independent marker of the quality use of medicines. Because in the area I work, I quite often hear the comments, oh, they're taking too many meds. We've just got to stop that. Mrs. Jones is on too many, Mr. Smith's having too many. A person maybe taking 19 medications, and we need to look at them and make sure individually to see if they're clinically indicated. And if they're indicated, then they need to be, if the benefits of those medicines outweigh the adverse effects of those medicines, then we keep them on the meds. But we still should review them because they could be stopped. Yeah, there may be ones which aren't clinically benefit to them. But we must not forget those people who are on, say, 4 or 3 or 2 or 5 medications, because sometimes we think, oh, they're not on too many, that's okay. Because those people actually might be on 1 or 2 that they shouldn't be taking. We need to look at every person and their comorbidities and see where they lie and whether they need to have those medicines. The polypharmacy, even though it's not a clinically useful independent marker of the quality use of medicines, we still should be should keep in mind that increasing those medicines will increase the risk of those adverse drug reactions and drug-drug interactions, and that is a concern in the elderly. Also, don't forget for the elderly people that there are also increased medication costs when they have them, which is a concern to them, and poor adherence to medications, because even though we're here, we don't want to poison people with their medications and make sure that they're kept safe. We also want to make sure at the same time that we actually are giving them, they are getting the medications that they need to have and aren't missing out on the benefits of those particular medications. The most frequent adverse drug reactions in the elderly, these are just in their groups. General gastrointestinal bleeding is up on there, right up there. Confusion, sedation and delirium. Postural, or we call orthostatic hypotension, that's where you go from a sitting or laying position and then up to a standing and the blood pressure drops, usually after 5 minutes or more. I've put those 2 areas, if they can see that hopefully on the web, they're in blue because they're the most common causes of falls in the elderly, and falls prevention is something which medications play, looking at their medications and trying to prevent falls. That's an area we need to actually review medications often with, because that is a common cause of mortality in the elderly. But we also get blood abnormalities, and they're termed blood dyscrasias, and I've just given some examples of them. A fairly common one with a number of medications is a low platelet count, thrombocytopenia, and platelets are needed for your initial stages of clotting. Therefore, people, if they're very low, can be at increased risk of bleeds. Vitamin B12 deficiency called pernicious anemia. There's a number of medications which can cause that to occur. I'll let you look up at all the adverse effects of having pernicious anemia with it, but it's significant. And just another example, low neutrophil count, and it's a white blood cell, but if that gets too low, then there's increased risk of serious life-threatening infections too. And cardiac arrhythmias is another big one. And when these occur, that causes the heart to beat out of rhythm, and they may result in collapse and death with that. So that's really just my little overview with it. I suppose what I'll finish off with myself in aged care is that we need to make sure that we're doing the right things with medications. And I put down 8 rights. Now, these 8 rights relate to my work in aged care, and this is with people who are administering medications, from packs as such, and they're using PRN and such. So you can pick out your rights that need to be there. They're not always 8. Some have 5 rights, some have 6. But I think this pretty well covers them all. And the thing is, are you giving the right person the right medication in the right dose, by the right route, at the right time, important, for the right reason, and then, if applicable, and this tends to be when you have documentation there, completing the right documentation at the right time, not after you've given everybody the meds, but individually, and then getting the right response. The right response is often relating to PRN when required, pro rata medications. In other words, if you're giving someone analgesia, does it help the pain? You find out half an hour later. So it's like that. And thank you. Okay.
Thank you, Mark. Thanks for sharing your experience and knowledge with us. We'll move on to our final speaker now, Nagar. So Nagar is an accredited consultant pharmacist with 13 years of experience in community pharmacy. She's currently the business development pharmacist for 777 Pharmacy Group, focusing on developing pharmacist professional services and community engagement. Her role as a consultant professional service pharmacist has provided Nagar with opportunities to work closely with patients, their families, and other healthcare professionals. She conducts home medication reviews, delivers personalised care, and uses her strong clinical knowledge to help with improving attitudes towards health and reaching the best possible outcomes. Nagar is an accredited instructor for mental health first aid and has had extensive training in integrative and nutritional medicine. Thank you. Pass over to you.
Thanks everyone, and thanks Alison for inviting me to share our input about this important topic. I think this is a really important topic because a lot of the events that occur, the adverse effects that occur are actually preventable. Dr. Lynch and Mark have shared with us already why some of these events occur. They've also explained about some of the, physical reasons as to why that elderly population are more prone to having these adverse events occur for them. So the part that I want to talk about and share with you is, as my experience as a pharmacist and seeing the older population come and present to community pharmacy, quite often with their carers, which could potentially be family, or quite often with carers and support workers that are engaging people from, say, arranged from their GPs or from other organisations to come into people's home, allow them to live independently but also receive support administering their medications as well. So it's really important, I suppose, for us to as care workers and support workers, whether it's family or an external organisation that's providing the support, to understand how we can help the older adults with managing their medications. Especially, as Dr. Lynch mentioned, that sometimes as we come into a role of a health support provider or a carer, we don't necessarily always have background on administering medications. We don't always necessarily have that understanding of how our body works and how the physiology of the body works. So it's important to, equip ourselves as support workers and care workers with some understanding of how we can manage questions and manage concerns that may arise. So I'll be talking a little bit about that today with some of the information that also was presented and referring to that as well. So I guess that we have already seen that a higher number of severe events occur in older adults. And the main two reasons, as we discussed already, is because frailty is quite common in older adults. The physiology of the body deteriorates as we get older. And also polypharmacy. So as Mark mentioned, there is quite often an incidence of more medicines being prescribed because our health conditions deteriorate as we age. And the challenges that occur, again, as was mentioned before, is that our gut moves slower, so medicines behave differently in the body. Also, what happens as we get older is we lose muscle mass and we get more fatty tissue accumulating, which then again changes how medicines behave in the body, so how they clear out of the body changes. Also, our detox organs change, as Mark mentioned. Our liver starts to deteriorate, the function of the kidneys starts to deteriorate, so things can build up in the body and change how our body responds to those. Quite often, as we get older, we forget stuff, and that's a wear and tear situation of our nervous system. And as our body capacity and the capabilities change in older adults, we do see an increased amount of change in their mental health. So quite often they get a bit depressed about the fact that they can't do things as well, and then that might mean that they're not looking after themselves as well. They might find themselves not eating properly, they might not be as active, they may actually be, from the pain and the changes in their health condition, they may be experiencing disabilities which might possibly make their mental health situation a little bit worse. And also that can lead to isolation, which might mean that they're not seeking as much support, they're not up to date with their information, they might not be sharing the changes in their physical condition with people. Just like Dr. Lynch was saying, the lady that actually called in, she was quite hesitant to talk about her other medications. So those sort of things can complicate how we can care for people and support them in their ongoing journey of healthcare. So knowing what outcome we want to get is really important. That we're looking for quality use of medicine. So whether it's a person that's at home, whether it's in a residential facility, as support workers, we're looking to make sure that the person is getting quality use of medicine. So what does that really mean? It is looking at the fact that medicines that are being taken are actually thoughtfully prescribed, so that the patient is actually sharing this information with their doctor or prescriber in a very accurate way. So they're actually giving the right information so the doctor can make the right decision as to what they're actually prescribing. We're also looking at appropriate use of medicine. So is this actually the right medicine for this condition? Is it safe? Have we tested for all the parameters that we need to consider before prescribing this medicine? And also looking at the evidence base. So all of a sudden we're looking at the fact that a medicine is an evolving science and we're always finding out about different things. So sometimes a medicine that used to be known as a really good option is no longer the best option. Now there's something better for that. So is a person being reviewed for this? Are we having conversations around these revisions? And also part of quality use of medicine, as mentioned before, is making sure that we're preventing adverse effects. So looking at constantly the response that we're getting from the medication, looking at any potential changes that are happening in the body. So the challenge that we have to make sure quality use of medicine is occurring is making sure that, I guess, the care that we're providing for our patients is coordinated. So what does that really mean? To me, as a pharmacist that's practicing in community, and the experience that I've had with all the patients that are coming in with their family as their carers, or the support workers that are coming in, the challenge is sometimes patients go to different pharmacies. The information that they get is different. The brands that they actually get dispensed are different. They look different. So confusion happens. Sometimes they go to different GPs. So in the same clinic even, they could be seeing different prescribers. And then there's a gap of communication. So this care coordination can actually be not to the best of interest of the patient, because quite often information can go missing in between. So I guess as care workers and support workers, it's really an empowering piece of knowledge to have that there are measures that you can start conversations about, so that the patient and their family and the prescriber can actually be united in the way that they're providing care. So things like chronic disease management plans that can be coordinated by the GPs are quite a good way of getting that started. If you've got a patient that you're looking after and they've got multiple conditions and multiple medications, they might be going to specialists, they might be seeing allied health people like physiotherapists and occupational therapists. Having a chronic disease management plan is really useful, because it's a platform where all the information is recorded. Hopefully they're seeing the same GP, same pharmacist, same allied health people, and they're all having conversations, they're all communicating. Letters can be exchanged, phone calls can be made, just because now there is permission from everyone to communicate properly. Because quite often, as pharmacists, I might have called someone and the doctor's only seen the patient twice and there's not a lot of information there. So then that can create a bit of delay in how we can provide the best care for the patient. Team care arrangement, again, a similar sort of situation where a doctor has referred a couple of different allied healths to help with supporting the patient's needs. There might be a pharmacist on there, there might be a physiotherapist or a podiatrist. So again, all of these people are allowed to talk to each other about how the patient is going. So, for example, as a support provider or a family member or a carer, when you go to the same pharmacy or you go to the same GP, you know that this information hopefully is in the same place. Mental health treatment plans, again, really becomes a good tool, especially if we're looking after an older adult who is starting to experience mental health challenges because of the fact that they're aging, there's wear and tear, there's body changes. Having resources like mental health team care plans allows, I suppose, an affordable way of us providing some form of support and counselling to this person, so they can start to have abilities and strategies around how they can manage their mental health. So I guess as we age, our abilities do change, but being updated and having a second opinion on how we can actually manage our mental health helps a lot. And quite often they benefit from having a chat to someone, and it breaks that pattern of isolation. It starts to implement some supportive mechanisms in their routine as well. So again, just awareness, this is a tool for us to have a conversation with the people we're supporting. Some of the information that I'll be talking about actually comes from, I suppose, the Royal Australian College of Physicians. These guys do a lot of research on updating how we prescribe medicines for older adults. Choosing Wisely Australia and NPS Medicine Wise, again, they're resources that are really easy to access. We can just go online and just type in NPS, and it comes up with a whole list of information for us as carers that we can tap into and use when in our daily practice we're updating ourselves. I guess one thing that I want to refer to is that when we are providing support to adults, it is a big responsibility. They are complicated in terms of how we're managing them. There's lots of medications, lots of different issues going on with them. So empowering ourselves as support workers is really important if we can go into a situation knowing what these medicines are doing and what sort of things we need to watch out for. It allows us to provide better care. So from those organisations, some recommendations are always made, and these are again evidence-based. So these are things that as support workers, if we're aware and we can keep this in the back of our mind, it's really helpful, because if we see that in the pattern of how this person's medicines are going, then we can raise an alert about that. So for example, some of the latest evidence are actually showing that we want to be having conversations about informed choices, so that the people are being prescribed medicines for good reasons. There is high quality of care. We're also having recommendations that basically we want to reduce waste of medications, and we want to make sure that extra tests are not unnecessarily given. So information gathering can actually be a really important part of decision making, and that's where things like care plans come into place, because if a test is already done and it's not necessary to do it again, then we don't want to be spending that taxpayer money on that either. So part of the recommendations, again, part of us empowering ourselves as carers with that sort of knowledge is, what are we saying? What's the pattern of medicine use that's being studied and is evidence-based? So we're talking about the fact that we want to stop the extra prescriptions that are not needed. We want to be stopping medicines that are probably not so safe. There's a risk versus benefit. So if the harm that may be caused by these medicines is higher than the benefit, then obviously we want to review that and not actually prescribe that. We want to be looking at medications that are no longer giving a benefit. So maybe a patient was prescribed this for a particularly good reason, they've used it, they've got the response and the benefit, but now it's no longer needed. So that's where the process of revising these medicines becomes really important. So as carers, again, it's really important that we constantly keep in the back of our mind, when was the last time we revised the medications? Did the doctor actually review this recently? Did the pharmacist review this recently? So again, asking those questions with the knowledge that there are some recommendations in place that maybe we can improve the regimen that we've given to the patient. The other part, which is more clinical recommendations from the Society of Geriatric Medicine, is really the types of medicines that they are finding that are no longer really that beneficial for older adults. So there used to be a pattern of recommending antipsychotics, for example, for patients that had dementia and also had behavioural issues. So aggression and not, disruptive behaviours can be quite common for people that are quite forgetful. Obviously, for understandable reasons, they get frustrated, and they used to prescribe, well, they still do to some extent, prescribe antipsychotics to manage those symptoms. But they're finding that the risks are actually greater than the benefits in that area. So really closely monitoring that, for example, even for patients that are living at home, we see that happen sometimes. So it's really important to review that quite closely. Looking at things like benzodiazepines, and these are things like sleeping tablets, diazepam, all those sort of things. And for the same reasons as Mark mentioned before, the clearance of these medicines changed in elderly because now we have less muscle tissue and more fatty tissue. So all of those things are not necessarily the safest choices for adults. Again, they cause an increased risk of falls, they cause more harm than they can do good. Looking at use of antibiotics, so those sort of things are quite common. Things like urinary tract infections are quite common in elderly people, and there are sometimes people that we come into the pharmacy and we see that they get given antibiotics as an ongoing thing. So looking at those and maybe questioning that as a support worker, if you're seeing your patient is constantly on antibiotics, raise that alarm and talk about that. So looking at, again, making sure that medications are reviewed, and as a support worker, that's a really good place for us to start. So this was a few simplified ways of us looking at how we can start the process. So we want to be looking for signs of change. We want to be looking for signs of alarm or concern. So especially for care workers and support people and family who are seeing a patient as an ongoing basis, looking for changes is really important, and actually asking questions around that. So what's happening? Are you actually experiencing this as an ongoing thing? Is it maybe just over the last couple of days? Is there been any changes in your routine? And also looking to monitor this change. So if something's all of a sudden changed, can we actually create a pattern? Can we look at what's happened before and monitor it for the next couple of weeks? Is it worsening? Is it going away? And also then finding the right resources. So looking at maybe the GP or the pharmacy, or even going online at the resources like NPS and finding out more about their medications. So empowering ourselves again as a support mechanism for this older adult to be able to give some more information. And also then contacting the right resources to ask questions and put them in contact with the right place. Because I think of support and care as the fact that we come from a space of love. And obviously, if we can provide this patient with as much information and as much support as we can, obviously then that's the best outcome. So there's two different aspects of care and support with medication management. One is the medication support. So this is where the person that we're looking after, the older adult, still has some independence happening. So they're actually still able to take their medicines on their own. But we, as support workers and care workers, we might be just providing some assistance in reminders. We might be providing some assistance with packaging, opening the bottles and things like that. And to that extent, it's a more basic level of support because the person is really self-sufficient to a great degree. But when it comes to medication administration, that becomes important because then now we're actually looking at what Mark talked about as well, to look at storage of medication and making sure that we're considering a whole heap of other things now because all of a sudden there's a greater responsibility on the care that we're providing. So we want to be making sure that over-the-counter medicines are actually looked at and considered. We want to be making sure that the prescription medicines that are in place are the right type, the patient recognises them, we recognise them as a support worker, and also if the patient is insisting or is actually being recommended effectively some complementary medicines, do these interact? Because complementary medicines are still medicines, they're just not as potent as the conventional medicines. So they do have potential to interact with medicines and cause harm. So we do need to be mindful of how we store and administer them as well. And also then looking at if the patient has now been seized, they're not taking a particular medication any longer, or if we've decided that some medicines are no longer good and gone out of date, how do we dispose of that? So making sure that they're not staying on the premises in the patient's home to cause further harm and error. And also looking at, Mark talked about this 8 rights of medicines, which is really effective as well, but some of the teachings that are going on in the trainings that are being provided are the 6 rights of safe medicine practice, and these are the basic ones where you're giving the medicine to the right person at the right dose, it's the right time of the day, and that makes a difference because obviously that our body's function changes throughout the day, and also keeping the right route of medication administration, the right dose and the right documentation. So to facilitate that, we're looking at how can pharmacy help. So if you're providing support to a patient in the community pharmacies can actually be a great source of support. Now, it does mean that sometimes we have to, for patients that have complicated needs, we do have to select the right pharmacy that is able to give these services, because there's obviously a whole variety of pharmacies available now. So some of them are focusing on giving the best price for the patient because that's what they're really looking for. But some pharmacies are focusing on how they can provide the best treatment outcome for the patient, which does mean that the pharmacists then need to take more time. They need to be more involved with the patient care. They need to be more involved with the care team of the patient, so they talk to the doctors a lot more. They provide management support in terms of constantly reviewing and following up with the patients. So sometimes if you're looking after a patient who has more complicated needs, as a support worker or a family member who's providing care, it's really important to then advise and talk to the patient and the family about which pharmacy are you going to. Are you actually getting the best service out of the pharmacy services that you're getting? So looking at what pharmacy can do, if you have a regular healthcare team, a regular pharmacy team that you're seeing, they can keep records, they can follow up, they can provide things like ongoing advice on the medication, because if a person has called up and expressed a concern, next week that same information doesn't need to be repeated to a different pharmacist if you keep talking to the same person. If you're providing advice on correct storage and medication, to the patient, and then you're following up with them. That can be an effective way of managing and preventing any errors. Pharmacy can be a really good place just to drop in the unwanted medicines. They're discarded for you, so you don't have to throw it in the bin. Making sure that also minimizing prescription errors by leaving prescriptions on file, because the pharmacy can then remind patients about when to collect their prescriptions. A lot of times, if people are finding transportation difficult, if care and support network is not available to get there on time, pharmacy can a lot of pharmacies can actually provide a delivery service for their patients. Sometimes there are special medications that pharmacies don't keep, and providing special orders, they can order it in. A lot of pharmacies now actually provide vaccinations, so if the patient can't go to their GP and they find it more convenient to pop into the pharmacy, they can do that as well. So these are some of the basic services that pharmacy provides. But in terms of really looking at managing medication and preventing harm and looking at reviewing medications, pharmacies can provide medicines lists, and that's something that I think is really important, especially as a number of medicines are increasing in a patient's treatment regimen, that medicines lists are handy. So having this in the home, having this on the app, like if someone's tech savvy and they're looking after someone and they would like to have an app just to be able to pull up when they're at the GP appointment, these are really important. So for example, the NPS website, the app that I've just put the picture of up on the board, this is one of the examples of the fact that they can actually have an electronic medicines list generated. So on that app, you can get information, dosages, possible interactions, so all of those informations can be there. But for the patient that may not be so tech savvy, having an actual hard copy of the medicines list is really, really important. So just folding that and putting that in their bag, if they're popping into the doctors and they can't remember what they're taking, that's a really good way of having that information handy. Dose administration aids actually make it really, really easy for us to get the 6 rights or the 8 rights happening a lot easier. So these are prepared at the pharmacy. Pharmacists always check them. The aim is that they are targeted for the patient, the medicines are correctly stored, they are packed at the right time of the day, and it is a really simple way of preventing errors. So it is an encouraging thing to see that a lot of people are using this now. Nowadays, coming from community pharmacy, I'm seeing that a lot more. A lot of GPs are actually recommending for patients to go on and have dose administration aids. So if you're supporting someone who's on multiple medications and you see that they don't have a dose administration aid, having that conversation and saying, okay, well, this actually takes the worry out of it. You don't need to be, fiddling around with different packaging all the time and looking at different medications. This allows more time to spend on doing other things. So it increases quality of life sometimes for some patients as well. So coming away from that, I guess looking at constantly reviewing the medication. So one of the resources that as support workers and carers and families we can provide to our patients is that reassurance to say, look, if you're not sure what's going on with your medication, just pop into the pharmacy. They have this great management tool where it's subsidised by Medicare, and it allows pharmacists to actually sit down with the patient, review their medication, give information about it, raise any concerns and alerts and talk to the doctor about it if need be, and basically follow up again from that date. 6 months later, we'll follow up with the patient to see how it's going on. So this is something that's really important, especially when a medication changes. It's really important where a new diagnosis is made. If the patient is experiencing any changes in their general symptoms, that could possibly be an adverse event. So this is a resource that can be used by the patient and their family. Following on from that, if something is picked up in that medication management, home medicines reviews are another great tool. So if there's multiple medications, sometimes there's physical issues for the patient. So for example, we're thinking, how are they faring manoeuvring around their home? We're noticing the patient is at a higher risk of falls. Can we go in and have a look and make sure that their home setup is okay? So this is what I do sometimes and what Mark does very effectively. We go into the patient's home, you assess their medication, you write a report to the GP, you come up with a medication management plan, and then the pharmacy that's involved with the patient makes sure that that's implemented. Again, for all of these measures to work effectively, it comes down to making sure that the support team is questioning things all the time, it comes down to making sure that we have the same consistent healthcare team, that we're talking to the same GP and the same doctor all the time and the same pharmacist all the time. So again, it's really important to be aware of what tools are in place, but how can we use them more effectively? So another service that pharmacy can offer is looking at providing medications in a stage supply. So even sometimes with giving dose administration aids, with some patients that I came across, I've seen that, especially those patients who are in pain or they're experiencing sleeping issues, it becomes common for them to use a medicine at a higher dose than what's recommended, just because they perceive that using more of this medicine is going to give them a better result. But then potentially, for all the reasons that we heard before and how older adults are more at risk of adverse effects and they're more sensitive to the medicine, that can be quite a dangerous thing for them to do. So pharmacy, at the request of the GP or the patient or the carer or the family, can actually make an arrangement where they can give the medicines in smaller quantities. This can be delivered, this can be collected, but at the same time it provides the medicine in the smaller quantities, hopefully making it safer for them to hold that quantity of medicine at home and use it more effectively and less tendency to create harm. So other resources that are available to care workers and support workers and families is really looking at information websites like the NPS, again, like National Prescribing Services, the government-funded body, have a lot of up-to-date evidence-based information there. So looking at all the different aspects of that, looking at their app, can be helpful to prepare us to go into help someone that has a complicated case. And every person will be different. So as support workers, you'll come across a whole variety of different people with lots of different treatment regimens, but looking at how can we individualize that, how can we personalize it, how can we prep ourselves going into a situation, looking at the different information that's freely available to us. So the Department of Health website, there's the aged care website, again, that gives us information about how can we organize support for someone. So as a care worker or a support worker, we might be going into a situation where we can see someone needs more help in their home. We can see someone is at a higher risk of sustaining injury. So going onto that website can actually give us somewhere to start on how to refer people on. And this is going back to where we were talking about finding the right resources, asking the right questions and connecting people. So the Scriptwise is actually an initiative that Pharmacy 777 supports. These guys are a charity organisation that their champion is actually Heath Ledger's father. So Kim Ledger has started supporting Scriptwise simply because of the medication misadventure that Heath sustained and unfortunately lost his life to. And the reason this is really important is because they actually concentrate on raising awareness around accidental overuse and misuse of medication. And sometimes that happens, especially in older adults, again, for all the reasons that we've heard, they are looking to create comfort, and accidents and overuses can occur, which can result in severe harm or sometimes loss of life. So it's important, I guess, to tap into resources like that, get ourselves educated around how we can prevent issues like that. MedAdvisor is just another app. It's a medication management app. Some pharmacies use it. It's a platform of recording all the services as well, like the other ones that we talked about, the meds checks and things like that. So some pharmacies will offer it to patients who are going to that pharmacy to keep the record, similar to the NPS medication list app. So these are some of the support resources that are available. And also looking at making sure that as care workers and support workers, you're supported. So your ability to cope with all the challenges and the concerns that get raised when you're helping an older adult is a big part of, I guess, the responsibility that you would have, because if you're not looking after yourselves, then the amount of support you can provide is obviously going to be hindered as well. So useful contacts for carers comes from the My Aged Care website. So making sure that you're tapping into that. If you have questions, if you have concerns, if there is pressures in the cases that you're supporting and handling, tapping into that is really good. The My Aged Care website also gives some information around how to go about finding daily living products, so things that support movement and assists with people's medication management and condition management. They also have some information and resources onto how to refer when there is a case that you might be supporting if the patient needs some financial assistance, or how to refer if they're developing disruptive behaviours through their dementia courses. So I guess all of these are really tools, and at the end of it, I would go back to the slide that we had, which was, I'll not use that now, but I'll looking at the fact that we actually just need to bring ourselves back to how we're supporting and caring for our patients. We're looking at asking questions. We're looking at the fact that we need to be aware that obviously all these medicines are there to help manage their conditions for the better, but unfortunately, because of all the reasons we've discussed, sometimes they can lead to creating more harm than good. And as long as support workers and care workers, we are there and we're asking the right questions and we're connecting them to the right place, quite often a lot of these issues can be prevented. So thank you for your attention. If you have any questions around how we can support, please raise them, let me know. Thank you.
Thank you, Sarah. What we'll do now is open up the floor. Did anyone have any questions at all for any of the three speakers? Or any questions on webinar at all?
We've got one online. So Jenny's asked who, Anne-Marie, in your stats you had that females were overrepresented in your calls. So she asked why you think elderly ladies are more effective. She suggested that is it because women live longer, or that single elderly men are cared for more?
I don't think single elderly men are cared for more. That would surprise me. I would have thought that certainly not my area of expertise, and I can't comment on it.
If I may jump in on that one, working aged care and facilities, women live longer than men. So there's a greater body of women there.
I was about to say there's a great proportion.
That's why it's...
But there's other factors as well.
Yeah.
There are more women live longer, so you I don't actually. But also, I think women are more likely to phone the poison centre. Men, same thing with presenting to a GP or whatever. It's men tend to shut down more. They're less likely to ask for help. It's women that tend to. So I don't think it's just one factor. There are certainly more women, and it's interesting if you look at PIC data across, and I think that it also brings up behavioural things when you're looking at age groups where the gender ratios are about equal. In toddlers, we have more males getting into things than females, and I think that's a behavioural thing. But as you move through the adult age group, they're about 50-50. But certainly in the elderly, across most things, including suicides. I'm not saying that elderly men don't suicide, but men are more likely to use other methods other than medication. So in terms of the sort of cases that we see, certainly in an elderly age group, women would be overrepresented. And it's not just that. Certainly there are more of them, and they're living longer, but there's also, I think, behavioural issues as well.
I was just also wondering if that's just a tip of the iceberg, the number that you've seen. Because
yes, I think this is grossly underestimated. I think it was mentioned, digoxin was mentioned, and clearly that's actually quite a common problem with people developing chronic digoxin toxicity in the elderly as their renal function declines. That would be picked up in adverse reactions. It wouldn't be within this therapeutic area. The number of calls to PIC, I think most of the data seem to be people calling from home and identifying an issue or a medication and then asking advice. We do get about 25% of our calls are from hospitals, but if we received a call from a hospital about an elderly person who was unwell because it may not be, we may get this drug profile, but we may not necessarily coded as a therapeutic error. It's this person's come in, they've been transferred in from the nursing home, they're on more than 5. I can tell you, bang, 12 medication, they're exhibiting this, their ECG showing this, and so that may not necessarily be captured as a therapeutic error then. You've just got this unwell elderly person in an ED. So certainly there have been mistakes happening all the time, and I'm sure that the pharmacists and the, home reviewers that it's complex. There's lots of tablets. They come in different forms. They have different trade names, and I think one good point, and that's very difficult for poisons, is that they often don't know, or they're reading things off the back of their dosette box. But just to have apps are great, but I don't think the elderly are that computer savvy. But just to have something on a piece of paper that says this is updated, this has been updated by the pharmacist, this is the latest, here's the tablet, so they can read off to you. It's such a useful thing, and they often don't have them.
And it's something then that comes to be the responsibility of the care person or the family to actually remind the pharmacist to say, I need another one of these.
Yeah.
As the medications change, when they go to the GP and come back with a new prescription, that's something you can ask the pharmacy. And sometimes I feel like as a profession we should be doing this proactively anyway, but obviously as I've discussed, there are different levels of care provision. So if you are going to a pharmacy where unfortunately they haven't caught up to that at this level where they're actually automatically providing that, ask for it. So as a patient, we can always be proactive as well.
If you don't want to go to your pharmacist, you can also order the NPS Medicine-Wise Medicine List booklet, up to 20 copies at a time from the NPS Medicine-Wise website, and they will post it to you for free.
Oh, that's good. I did do that, yeah.
Oh, okay. So I do the My Medicines and Me questionnaire at Comwa, which is a psychotropic-based medication idea because of the interest in the older population. But it's a communication tool developed by a pharmacist here to start conversations about the adverse reactions. And I'm teaching people how to have those conversations, which are challenging because the adverse reaction with psychotropics are really high. It's very psychotropic medications. I'm rambling. It's random. But because of that, I've done a lot of Googling into medication management techniques and stumbled across that. So we let people know.
So why do they tell you that they don't want to go to pharmacists?
No, people do go to their pharmacist. So for us, for what we're doing, for my project, the conversation is around psychotropics, mental health meds. If the side effects suck massively, they can go to their doctor, they get told it's a side effect. It's a very you come from a place of marginalisation if it's a mental health diagnosis, or if you're a person living with comorbidities where you don't have as much of a voice. There's the stigma of if you remove a mental health medication that the person could become unwell. If you take it out of the mental health context and it's a benzo being prescribed for something else, people may not realise that something could be attributed to the side effect. So the tool is a tool for self-determination and to start a conversation with the GP where hopefully the person's experiences are heard and a two-way conversation to facilitate true shared decision-making around prescription can occur. I recommend people talk to their pharmacist to get information because it's that information that creates that empowerment that allows people to do that self-advocacy and that underpins the project. We're actually getting the My Medicines and Me included in home medication reviews is my understanding, just as an optional tool for that. But it's a difficult conversation for a lot of people to have, so that's what I do, but that's how I know about the medicine-wise thing. So please do the medicine-wise thing.
Yeah, I think that's a question about.
Yeah, I just want to actually ask either of you, generics versus the real medication, because I have been told stay away from generics. There's a lot of bad things or, compounded things that get put into that. So,
Look, I suppose if I can jump in with this one, when a medicine's first research one, there's a company who's a proprietary company that gets to, they do the research, they put it through jump through all the hoops, and therefore they get the proprietary as a reward, and they should get it because it costs them a lot of money, it's a lot of time. They're allowed to produce that medicine for a number of years, and no one else is allowed to touch it. I wish they hadn't used the term generic, because generic is actually a good term. Generic means the name of the drug rather than the brand name. So, for example, Notin, for example, which is a brand name, the generic name of the drug is atenolol. Atenolol is the beta blocker with it. So what happened with Notin, well, actually, it was actually Tenormin was the brand which started off with that one, with atenolol. And then when they're proprietary over a number of years, then they lose that right to be the only one to produce that drug. And then people can produce generics, which are other people producing atenolol and calling it other things, or they may call it atenolol. Look, in actual fact, for the vast majority of drugs, there's not them putting other things in it. The drug itself, in this case, atenolol, is the same drug. It has exactly the same effect, and it is equivalent to the other ones. And people will have their preferences, personal preferences, and such like that. But in the majority of those, it's exactly that. So it is the same. The excipients might be slightly different. There might be a bit more magnesium in this one, or a bit less than that, but the drug is the same. There are exceptions. For example, warfarin. There are two brands of warfarin. One's called the Coumadin brand, the other one's called the Marabin. Even though they're now owned by the same company, the Marabin have a 1 milligram, 3 milligram, and 5 milligram strength. The Coumadin have which is not used as often, but I think it's a 1, a 2. They used to have a 2.5 and a 5, I think, but they don't recommend you swap brands of that. So there are exceptions, there are circumstances, and then you see that as far as the rules go, they have to then list that on the computer, take over from there, from the PBS.
With most of the medicines, what the Therapeutic Goods Administration, which is the body that looks after regulating medicines, they've determined that active ingredients are exactly the same, so therefore they're allowed to replace. With certain things like warfarin, they've said that we can't guarantee that the way this medicine's brand behaves in the body versus this medicine's brand is going to be the same. They can't guarantee. And the simple reason is because it's so sensitive, that particular type of medicine is so sensitive. Anecdotally, I've seen a lot of people recently, especially with the changes of the different medicines brands that have come in, that they've come in and they've said to us that this doesn't work as well for me, or this is giving me side effects. Now, we don't have data around that we can say. However, from my experience, what it has been is those particular conditions that, for example, are quite sensitive to the chemistry of the body. So, for example, things like migraines, for example, things like mood disorders like depression. These sort of conditions are very sensitive to how our body's chemistry functions. So if a medicine that was being used before, even if the compression of the tablet that's being made is different to this new brand, how it dissolves in the body, how quickly it dissolves in the body, may actually impact the outcome of the medication. So for example, I had a lady who was using a particular brand of migraine medication, and then she came in and she was swapped to a different brand from a different pharmacy, but she came to collect her new repeat from us, and she said, I don't want this brand anymore because when I was using the previous brand, I wasn't getting migraines, but with this new brand, I am getting migraines. So it goes to show that even though the active ingredient is the same, it may just be that this generic company has put a different compression on their tablets, so maybe it's dissolving a bit quicker, and maybe the chemistry of the body is slightly changing, which for this person means a different outcome for their medication.
And let's not forget the placebo effect, and that's in all our minds. In all our minds, if we believe something is happening, it will often happen, and if we don't believe it's happening, there's a fair percentage of time it won't happen. And that's with all of us. So, I mean, when we look at drugs themselves and we look at the placebo effect, for example, we talked about behavioural and psychological symptoms of dementia, and they talked about those drugs that could help reduce those agitation and aggression. The antipsychotics achieve that 68%, which sounds absolutely fantastic. When you found the placebo, the sugar tablets achieved 50%. So the net effect was actually 18%. But 50% of people were getting improved reduction in symptoms on a sugar tablet. So our mind has effect. But to go back to answer your question, in most cases, the generic pharmaceutically, pharmacologically, pharmacokinetics and pharmacodynamics will be identical and should be, or as close to that it shouldn't be noticeable to the other brand. Does that answer it? Yeah. But in real life, that's not going to actually pan out in people's minds as having the same effect.
So the answer to that is that we do need to be respectful of if someone is coming in and actually saying that my experience with this is different. So if the pharmacy is saying that, well, generic medicines are the same, to a great degree they're right, but at the same time, our role is that we need to respect the experience of the patient and put them back on what they were comfortable with.
And sadly, for those that want to stay with the original brand, and I support those people that want to stay with their original brand, is that they have to pay a premium to get that then after that. We can't do it without that because the science says they're the same. The people, and I don't disregard that at all, feel that it's different, and it will be different for some people with it, definitely. But because the science is the same as that original company, sometimes I believe they allow generics to come out a little too quickly, to not allow the actual company that produces the drugs to get a fair return over that time for all the research and money that's spent on it. Yeah. Does that sort of answer your question? Yeah.
Okay, time for one more question. Anyone? No. I actually have a quick question. How will the new My Health Records initiative that the federal government's rolling out impact on, I guess, medications and the pharmacy experience?
That's a great question. So with My Health Records and how it actually can that to influence pharmacies, that potentially we can see some other records that we don't have access to. It is to some extent a contentious thing at the moment because a degree of confidentiality exists within that spectrum. So whether patients actually choose to disclose all that information is up to them. So we still haven't really practiced it in pharmacy as such, especially in the last sort of 6 months where it's been talked about. Only a few pharmacies have adopted it, and even within those few pharmacies, there are already sort of breaches to say that someone's clicked on something because they thought that information was useful, but the patient has complained about the fact that why did you look at my information? So overall, I think it's a good platform. It's a good idea to have shared information. I do think we still need a lot more refinement around how that information is accessed and who puts information on, because not everyone is using My Health Records at this stage. So it's still an incomplete platform at this stage, but the idea is really good. It's the same idea as
and they never will be, or use it, unfortunately. And not unfortunately, I mean, if you go on mental health, I know so many people will just opt out, and one reason alone might simply be they want to be able to have affordable insurance, a practical reason. So if an insurance company finds out they've got depression, then the premium is going to go through the roof because they're going to be.
or even
There's lots of reasons.
Also, I don't want a stomachache being attributed to anxiety, or I don't want the fact that I've come in a good mood to a new GP and then seeing bipolar on my record and then going, oh mania, I can't treat you, I'm harming you that way.
But
I don't want my
people,
lesbianism to be
that's right.
disclosed.
But those people that decide they want to do it, and that's fine if they want to do it,
They
then I
can
think
do
it may be useful too. But the percentage we'll find out. So.
Also, the medication information that's on there will be what has been prescribed and dispensed, and that list will only be as updated as those contributing to it have been. So for an older adult who may not have been to the doctor in 6 months, their medication could have changed immensely in that they may have been prescribed something and never started taking it, and all of those things. And then they can go to emergency with anything or pull up their medications list on their My Health record because they have access, and they can be like, this is what I'm on, and that's not a true reflection. You know, my medications list would have 6 things that have been prescribed to me in the last 12 months, of which I'm not taking any in the way that have been prescribed because I've had those changes with my doctor, but that was never updated through a prescription because I had those tablets there, and my psychiatrist and my psychologist and my GP and my neurologist and I all work really well like that. So, and my GP too. But it will never be a complete list. That is a true reflection, and one of my big fears, if you take out the stigma, if you take out the mental health, one of my big fears that people going, but it's going to be so fantastic that my doctor, that my pharmacist can see everything, is that if we treat that system, if we treat it like that, that my doctor has a complete picture of me, or my pharmacist has a complete picture of me, and I walk in. That's not true. You don't have a complete picture without involving me in the conversation. If you look at all the evidence, if you look at all the latest research, we are leading back into person-centered care, true person-centered care, which is what you have spoken so passionately about today. It's what I do around the shared decision-making. It's what so much support. It's just come out in the National Mental Health Principles. It's coming out through WAFA as a scientific point. It's coming out nationally. It's really important. And if you sit there and go, but this computer screen that is not a true reflection means that I don't have to have a deep conversation about your history because I've got it, that's not okay. You're erasing my experiences, which are so valuable, especially in the case of medication, because I can tell you right now, Eplin for me is the worst thing in the world, and I can tell you that and why. All it's going to say historically is it's been prescribed and then not continued. It's not a complete picture, and they're erasing that voice. Sorry, I have a bit of a soapbox.
Alright, great. Thank you. Thank you. That kind of wraps up today. Would everyone join me once more in thanking Anne-Marie, Mark and Nagar for taking the time out?